Evaluating a child's growth is really at the heart of pediatrics. But when that growth starts to slow down, it can feel like you're trying to solve a puzzle with a ton of different pieces. So where do you even start? Let's walk through how to tackle it, step by step.
Okay, so this is a super common scene in any clinic, right? The parents are worried, and now it's up to you to figure out if this is just a normal thing or maybe the very first sign of something else going on. Everything, and I mean everything, starts right here with this one question.
Before we can even begin to think about what's abnormal, we have to be absolutely rock solid on what's normal. Understanding typical growth isn't just a starting point, it's the foundation for every single decision we make after this. So let's build that baseline.
Man, that first year of life is just an explosion of growth. It's incredible. Just think about it. A healthy baby is going to double their birth weight by 4 months and then triple it by their first birthday. These aren't just random numbers. They're vital signs that tell us so much about a child's health.
And I am not exaggerating when I say this. Seriously. More than any fancy lab test or expensive imaging, this simple chart, when you use it right, is our most powerful tool. It literally tells the story of a child's health over time.
So what this chart really does is it gives us a visual story of a child's journey. Every little dot is a measurement we plot against these percentile curves, which basically show us the normal range. But our goal isn't just to see where they land on one single day. We want to see if they're following their own curve consistently over time.
All right, and that leads us to the real twist in our case. What happens when a child isn't following their curve? This is where our job as clinicians really begins.
So, first things first, we need a solid definition. We call it short stature when a child's height drops below that third percentile line. That gives us a clear, objective line in the sand where we say, okay, this needs a closer look.
So we've confirmed it. The growth curve has flattened out, it's crossed percentiles. That's a big deal. Now the first instinct is to just order all the tests, right? But hold on. Before you do that, there is one key question that's going to guide your entire workup.
And really, that big question boils down to this. Is this child perfectly healthy but just small because of their genes? Or maybe they're a late bloomer? Or is this drop-off a warning sign of an underlying disease? Our entire investigation depends on figuring this out.
Okay, this is where we put on our detective hats. We're going to use some specific tools and clues from the patient's history and exam to sort out what's totally benign from what might be a serious red flag. And the first tool we're going to pull out of our toolkit is the bone age X-ray. It's a really simple test that gives us this incredibly powerful piece of information. Does the maturity of the skeleton match the child's actual age in years? The answer is a huge first step in separating what's normal from what isn't.
And this is perfect because it breaks down the two most common and totally normal reasons for short stature. On one side, you've got familial short stature. Here, the bone age lines up perfectly with their real age. They're just programmed to be smaller. On the other side, you have constitutional delay. Here, the bone age is younger than their real age. These are those classic late bloomers who are going to catch up later and hit a totally normal adult height.
But this is where our specific case gets tricky. A delayed bone age by itself could just mean they're a late bloomer. But when you see that combined with a slowing growth velocity, meaning the kid isn't growing as fast as they should be, that is a major red flag. That combination really forces us to start hunting for an underlying problem.
Okay, the next clue we're looking for is in the child's body proportions. We actually measure the ratio of their upper body to their lower body. If that ratio is off, with limbs that are short for the torso, that points us toward a skeletal problem, like a skeletal dysplasia. But if the ratio is normal for their age, it means they're proportionately small, which steers our investigation more toward a systemic or endocrine cause.
Now listen up, because this is a big one. For any girl with unexplained short stature, this next step is an absolute must-do. We have to order a karyotype. It's a test that looks at the child's chromosomes, and we do it to rule out Turner syndrome, a classic cause of short stature in girls that we just cannot afford to miss.
So let's recap our patient. We've got proportionate short stature and a slow in growth velocity. The clues are all starting to point in one direction, an endocrine issue. So let's zoom in on one of the most important possibilities, growth hormone deficiency.
Kids with GHD often have a certain look. Besides the slow growth, you might see what people call cherubic, or kind of childish facial features, maybe a prominent forehead and a little extra fat around the middle.
These physical clues can be subtle, but they're incredibly helpful. Now think about this. The signs don't just magically appear when a kid is 4. The clues can actually be there right from the very beginning. What are some of those really early warning signs we might see in a newborn?
And here you go. A brand new baby with dangerously low blood sugar, jaundice that just hangs on for way too long, or a micropenis in a boy. These are massive red flags for a problem with the pituitary gland, which is where growth hormone comes from.
Okay, so we think we know what's going on. How do we prove it? Well, we start with a screening test for something called IGF-1. See, unlike growth hormone itself, which shoots out in pulses, IGF-1 levels are nice and stable, making it a great marker. If that's low, we move to the gold standard, a GH stimulation test, where we challenge the pituitary to see if it can even release the hormone. And finally, an MRI is critical to look for any structural issues in the brain. So, we've followed the breadcrumbs, we've run the tests, and we have our diagnosis. What's the big takeaway here? What's the final chapter of this story?
And honestly, this is the part that makes it all worthwhile. Growth hormone deficiency is treatable. Getting the diagnosis right and getting it in time means we can actually intervene with treatment and help that child reach their full potential.
So let's wrap this all up into your go-to game plan. It always starts with the growth chart. Is there even a problem? From there, bone age and proportions help you sort out the normal stuff from the more worrisome causes. You screen for other diseases, and you always remember that karyotype in girls. Following this logical flow turns a confusing puzzle into a problem you can actually solve.
Because when you get right down to it, this is about so much more than just lines on a chart, isn't it? It's about finding conditions we can treat, easing parents' fears, and making sure that every child gets the best possible shot at a healthy life. That systematic approach, it's not just good medicine. It can literally change a child's entire future.